So we were so thrilled. HFA had an opportunity. We have been wanting to partner with the amazing Janet Brewer from Chess for a really long time. And I just want to share a short bio about her, and then I'm going to turn it over to you so that she can share a bit about Chess. Janet Brewer and Eric Lowe founded Chess Comprehensive Health Education Services in 2009 to provide support and services for those affected by inhibitors, given their own personal experience living with one. They continue to host the only national family camp and adult men's retreat dedicated to those with an inhibitor. Chess supports the ultra-rare bleeding disorder community through their One Drop Rare Bleeding Disorder Summit and Women with Coagulation Disorders program, Ladybugs. As a retired elementary special education teacher and mother of 3 children, all affected by hemophilia A, Janet has spent a lifetime advocating and creating inclusive, intimate learning environments that facilitate safe spaces for community growth, independence, resiliency, and acceptance. And I could not think of a better person or better organization to partner with to present on inhibitors and acquired hemophilia. And she's just been such a joy to work with. So I'd like to introduce my friend Janet to talk to you a little bit about Chess.
Hi, everybody. Thank you, Shelley. I too am thrilled to be able to have this partnership with HFA. As a matter of fact, there was a member of the HFA board who has an inhibitor at our very first inhibitor family camp, which seems hard to believe that it was back in 2010 at a camp called Victory Junction in North Carolina. So as Shelley said, I had a lot of personal experience as a mom. I think it's my most important experience, honestly, being the mother of 3 children, all of whom have been affected by hemophilia and specifically inhibitors as well. I have both of my boys had an inhibitor, one still has one. And I can honestly say, and I still say that having just hemophilia is so much easier than hemophilia with an inhibitor. It's been a ride. I can't tell you that it was always fun. I can tell you that it was always bumpy, and that we just kind of learned that if something strange was going to happen, it was going to happen in our family. And we learned to embrace that. We also learned to not live life by our Bethesda unit, which was a really tough transition for all of us to finally learn that, you know what, we're just going to go by what's going on in his body, and what his symptoms are. And again, I'm not a physician, and a physician probably wouldn't tell you to do that, but I can tell you that as a family member living with this, I do remember those phone calls from the hematologist telling me, all right, it's this or it's that, or my son and I making bets at his treatment center, visit to say, okay, so how high do you think it is this time? And you know what? We just kind of learned overall that we just took one day, one moment, sometimes 5 minutes at a time as we managed our inhibitor journey. So as Shelley said, we still have a large number of programs that are beneficial for the inhibitor community. Please feel free to check us out, check out our publications. All of our early ones speak a lot about inhibitors, and I'm just really excited that Dr. Bobby Tran could join us this evening. And I'm sorry, Shelley, I hate to steal your thunder. And I'll let you do the rest of his introduction. But Dr. Tran was someone that, I was always, that we were so lucky to know from the inhibitor summits back when, there were so many of us that went to them that was supported by Novo Nordisk. So again, I thank you so much for being here. Don't ever hesitate to reach out to me at Chess. And I hope that this evening is a good one for you tonight.
Thank you, Janet, and thank you for being here as one of the co-sponsors. We're thrilled to have you. And of course, HFA is the other co-sponsor of this evening. We were founded in 1994 as a national nonprofit organization to assist, educate, and advocate for the bleeding disorders community. Our educational webinars are put on by a number of different sponsors, and we thank them so much for sponsoring these programs so that we can bring these webinars to you and share this critical information. So thank you so much to our sponsors. And I want to introduce to you Dr. Bobby Duck Q Tran, MD, MSc. Dr. Tran is an assistant professor in the Department of Hematology and Medical Oncology at the Emory University School of Medicine in Atlanta, Georgia. He is an adult hematologist in the Hemophilia of Georgia Center for Bleeding and Clotting Disorders of Emory. He received his medical degree from the University of South Carolina in Columbia. He completed a residency in internal medicine at the University of South Florida in Tampa, where he also served as chief resident. He then completed a fellowship in hematology at Emory University. And I think that there is no better person to speak to our community on hemophilia and specifically on inhibitors and acquired hemophilia. So thank you, Dr. Tran, for joining us this afternoon/evening. And I am going to turn it over to you as I give a reminder that we have that Q&A section. So as you listen to Dr. Tran's amazing presentation, slip your questions in and we will make sure to get to them at the end of this presentation. Thank you, Dr. Tran.
Good evening and good afternoon, everyone. I want to thank the organizers of this meeting for the invitation to present to you guys tonight. Here are my disclosures for your review, and here are the objectives for the talk tonight that I hope that you guys will be able to identify after I finish presenting tonight. So speaking of inhibitors, what exactly is an inhibitor? So an inhibitor is essentially an antibody. And so for you to understand this, it is something that is produced by the immune system in response to an antigen, okay? And the immune system in our bodies should be able to tell the difference between a self-antigen and a foreign antigen separately. There's two different types of antibodies that can be formed. There are alloantibodies and autoantibodies. And so alloantibodies are those that work against alloantigens introduced to the body, okay? So think of this as, for example, factor that is being infused into the body, okay? So that would be, you're producing some factor, but you need additional factor. So that additional factor can be considered an alloantibody. And then that therefore makes it an alloantigen. And then an autoantibody is something that reacts to the components of the body's own tissues and organs, okay? And this is important to understand the difference between inherited hemophilia and acquired hemophilia. And so inherited hemophilia or congenital hemophilia is what most people know as being passed down from family members. Whereas acquired is that of which it just develops later on in life, okay? And when I was first asked to discuss this topic, it's really hard to kind of divide this topic out because the audience is such a diverse population, okay? And so to try to integrate the discussion of what this is and also the diagnosis and the treatment options, I've tried to color coordinate the slides as well as include the abbreviation IH for inherited hemophilia with inhibitor. And then also I've abbreviated acquired hemophilia with inhibitor as AH, okay? So you may have heard a lot about different types of hemophilia with inhibitor. Sometimes providers in the community, the medical community, is not very good about saying this long term or both of these long terms completely. So in the green box, you can see inherited hemophilia with inhibitor can be called any of these other things, okay? Additionally, with acquired hemophilia with inhibitor, sometimes the medical community just calls it acquired hemophilia, but it's implied that it's acquired because of an inhibitor. And so hopefully this chart gives you some understanding or some better understanding of the terminology that the community uses. So the coagulation cascade is probably something that you've seen before. This is how our body forms clots. And both inherited hemophilia with inhibitor and acquired hemophilia with inhibitor affects this area right here. So specifically with inherited hemophilia, it would be factor 8 or factor 9 deficiency, whereas the majority of acquired hemophilia is factor 8. And that is what is affected in the coagulation cascade. So I'm going to be hopping back and forth between hemophilia, inherited hemophilia and acquired hemophilia. And again, the color schemes hopefully will make it a little bit easier for you all to follow. So starting with inherited hemophilia with inhibitor, this is neutralizing alloantibodies exposed to exogenous factor 8 or factor 9 being infused into the body. The rate at which this can develop is predominantly in severe hemophilia A patients, and sometimes it can be also seen in mild or moderate hemophilia A patients. It's more rare in hemophilia B, but it does happen. And predominantly this affects males rather than females. And the reason is because a lot of females who have hemophilia have a very high, much higher percentage of factor that they produce. And so when they're getting this infused factor, their body doesn't mount a response like they would if their factor levels was undetectable or less than 1%. So when would you go down the route of suspecting an inhibitor development? So if there is ineffectiveness with factor replacement, that is one time that you should definitely try to work this up and get this further explored. For hemophilia B patients with inhibitors, allergic reactions and kidney issues can actually occur as well. Typically, what we've seen in larger studies is that inhibitors will form within the first 75 exposure days. The typical age of diagnosis is usually in childhood, but it can be seen later on in life, especially in those with mild or moderate hemophilia who have not been exposed to a large degree of factor products when they were younger. So with inherited hemophilia, the primary site of bleeding is in the joint, and this is known as a hemarthrosis. Subcutaneous, muscle, retroperitoneal, genital urinary, and also intracranial bleeding can occur, but they are less common. So I pose this question, what if I have inherited hemophilia and never use factor products would I develop an inhibitor? And so if you've never are exposed to outside factor products, then the answer is simply no. You would not need to live in fear for developing an inhibitor. But the reality is that with lower factor levels, we will eventually need some replacement at times of, say, surgeries or procedures. So if you go throughout your entire life without any surgeries or procedures, then you would not ever need factor. But that unfortunately is not the case. And so there were a couple of studies that have been done that look at what are risk factors for inhibitor development. And this study here from Dr. Gao that was published in the Blood Journal in 2007. This was also called the Canal study. This looked at the relationship between treatment characteristics and inhibitor development in previously untreated patients with severe hemophilia A. And some of the modifiable risk factors that were noted were age of treatment, intensive treatment. So they define that as greater than 5 days of consecutive treatment at time of surgery. This increased your inhibitor development risk by a little bit more than 3-fold. And then also those that were not on prophylaxis. Some non-modifiable risk factors for inhibitor development, included severe disease of hemophilia, as well as high-risk mutations. And additionally, if you had positive family history of hemophilia with an inhibitor, you were 3-fold higher risk of developing an inhibitor than somebody without a family history of hemophilia with an inhibitor. They did look at family history of hemophilia, period, and there was no difference in inhibitor development. And then lastly, one of the non-modifiable risk factors was that they recognized that Black race increased the risk 2-fold for inhibitor development. So now going on to kind of talking about acquired hemophilia A with an inhibitor. So how often does this happen? So first of all, how does this happen? This happens by neutralizing autoantibodies. So essentially your body is working against your own factor VIII, okay? And so this is much more rare than inherited hemophilia with inhibitor. And so the annual risk is, or the annual percentage is about 1.3 to 1.5 per million. And so if you think about it, it is a pretty small number. And it typically affects the majority of patients are older, and it both affects males and females equally. And then there's also a small peak for younger females as well. And this small peak is typically associated with pregnancy or autoimmune conditions. And in the literature, there's been reports of high morbidity and mortality. And I think a lot of it is because it isn't recognized or it isn't diagnosed. And so, when I was asked to give this talk, I thought that this was very appropriate because, this empowers the patients to be able to advocate for themselves because this is a pretty rare condition. So with acquired hemophilia, the typical presentation is more so bleeding, and it can be spontaneous, it can be traumatic, or it can occur around procedure time. And about 70% of the time, it's pretty serious on presentation. And 30% of the time, it is just picked up by laboratory testing, and patients don't actually have any bleeding symptoms, okay? And in these individuals, they have grown up all their lives with no bleeding issues whatsoever. They've had, say, their tonsils taken out, their adenoids taken out when they were younger. They've had surgeries of different sorts when they were younger, and there was no bleeding complications with it. And so as they get older, they start noticing some of these easier bleeding symptoms. And there is no family history. This is not noted to be similar to inherited hemophilia, where there could be a family history of bleeding disorders. The site of bleeding for acquired hemophilia can be a multitude of sites, but this study here that was a surveillance study done over in the United Kingdom looked and noted that subcutaneous or bruising was noted in 80% of the people, as were muscle bleed, GI bleeding, GU bleeding, and also retroperitoneal and brain bleeds. But these were a lot more rare. And so what can bring on acquired hemophilia? Well, this was a study by Dr. Pai, and you can see that half the people, so looking at the idiopathic means they don't know. There's not an associated condition. But you can see that the other half is or can be associated with cancers, autoimmune conditions, as well as in the rare potential causes of infection, as well as being drug related. So with this, I'm going to move on to kind of how do we get a diagnosis of an inhibitor. And so it first starts with clinical suspicion. And depending on the symptoms, this should be worked up further. And the reason why this slide is white and the next few slides are white is because this is both applicable to inherited hemophilia with inhibitor and acquired hemophilia with inhibitor. So it doesn't distinguish between alloantibodies and autoantibodies. So the testing is done the same way. And so typical laboratory testing would be some of these items listed here, okay? And expected lab findings would be that of a prolonged APTT or prolonged PTT. It's the same test, but different medical providers use different abbreviations. Sometimes mixing studies would be helpful, as well as the actual factor levels themselves. Sometimes there can be interference from other existing conditions, like a lupus anticoagulant. Sometimes this can cause interference. And so that is part of the initial laboratory testing as well. And then we go on to testing. If the factors are low, then we go on to testing the inhibitor level, which can be known as the Bethesda inhibitor titer or the chromogenic inhibitor titer. So additional laboratory testing that would kind of be helpful in inherited versus acquired hemophilia. With inherited hemophilia, as I noted before, knowing the genotype of the patient or family member may be helpful, because it can give a better idea of how well they may do with or how well they may, or at how high of a risk, they could be for developing an inhibitor. With acquired hemophilia, there can be other labs that are helpful, one being the porcine or pig factor VIII inhibitor titer. And I'll go into that a little bit more in the next few slides, as well as hepatitis B testing, as one of the drugs that is used to treat acquired hemophilia could potentially reactivate hepatitis C. So knowing the status would be helpful ahead of time. So with factor VIII specifically, there's two types of factor VIII clotting activity that can be done. And I just wanted to kind of mention those so that the audience here has a better understanding of what exists out there. So the one-stage factor VIII clotting assay is easy to perform, and it's generally provided at most hospitals that do provide factor VIII testing, okay? And this is because it's easily automated and it's relatively inexpensive. However, the one-stage factor VIII testing can have interference, which can lead to misleading results. The chromogenic assay is a two-stage test, and this is not susceptible to those interferences. However, it is a little bit more labor intensive, and so the laboratory would need more manpower to do it. Now, most HTCs should have access to both, and that would be an important thing, especially for patients who are being treated with one of the drugs that I'll be talking about in a later slide, known as emicizumab, which should only be used with the chromogenic factor VIII, because the one-stage factor VIII would give skewed results. And so once you have labs that are consistent with an inhibitor presence, you'll see that the PTT is prolonged, as mentioned before, and then you'll see low factor levels. And so what is happening is that these yellow, it looks like little Ys on its side, are binding all the factor. And so, and it's not making it readily available to go to sites of bleeding. And so here, in order to give better guidance on how patients should be treated, patients have been divided into high titer or low titer, and that magic number is 5, okay? And so those that are less than 5 are considered low titer, and those that are greater than 5 or equal to 5 are considered high titer. And so with treatment options, again, this is for inherited hemophilia with inhibitor. And after I'm finished talking about this, I'll go on to acquired hemophilia with inhibitor treatments. So with inhibitor treatment in the inherited hemophilia with inhibitor population, it's twofold. One is to treat the bleeding, and the second is to get rid of the inhibitor, and that's what the eradication of inhibitor is. And so for treatment of bleeding, again, I had mentioned and emphasized the breakdown of the inhibitor titer. So if you have a low inhibitor titer, then you can be treated with human factor VIII or the recombinant factor VIII, and that would require potentially a higher dose to basically overwhelm the system. Additionally, emicizumab has been more recently approved as well to be considered as a treatment option as well. Now, in the high titer group, emicizumab remains an option. And then if you don't want to use emicizumab, then an APCC would be an option, as would be a recombinant factor 7A product. So the recombinant 7A product and the APCC are considered bypassing agents. I have a table here to kind of give a little bit more guidance as far as, okay, the comparisons between the two. And as you can see, the third line where it says hemostatic efficacy, that's how good is it at controlling bleeding? And both drugs are, or both categories, I should say, are good at controlling bleeds at around 80% efficacy. And there's not one known quality of a patient that, or characteristic of a patient that makes one better than the other. Now, looking at the different half-lives, which means how long does the product stay in your system, you can see that the APCCs, it stays in your system longer, and so you don't have to dose it as frequently. However, one of the downsides of the activated prothrombin complex concentrates is that it's a much higher volume. And then also with the activated prothrombin complex concentrates, there is also a risk of amnestic response, and this cannot be used for hemophilia B patients with inhibitors. And so, so with the recombinant factor 7A, one of the disadvantages is that that would require you to have more frequent dosing. And so with the Hemlibra or Emicizumab, Hemlibra is the brand name for Emicizumab. It's a, so this is specifically used for those with factor 8 deficiency with or without an inhibitor. And so this is not approved for factor 9, but essentially what factor 8 does is you can see that factor 8 in the body will bring factor 9A together with factor 10 right here into this in order to form activated factor 10A. So emicizumab, what that does is, so with factor 8 deficiency, they're missing this part. And so the emicizumab essentially is a factor 8 mimetic, meaning it mimics the actions of factor 8 to bring factor 9A and factor 10 together in order to get factor 10 activated. And the administration route for this drug is subcutaneous. And so that is a little bit different than the recombinant factor products. And then also the dosing frequency is after the loading is every 1, 2, or 4 weeks, depending on what regimen you're on. This is a much longer half-life, so it stays in your system a lot longer. And again, it has been approved for severe hemophilia. So I should say, it has been approved for inherited severe hemophilia A with and without inhibitors. There is a black box warning, so you should not use this drug with an APCC due to the potential clotting risk. And then also one thing to keep in mind if you're on this is that the emicizumab will actually affect the APTT 1-stage factor 8 activity and the Bethesda assays for inhibitors. And so again, you should only use the chromogenic assays. When this drug was initially coming out, I actually made the mistake of ordering a 1-stage factor 8 activity, and the patient I knew had not infused any factor 8, and their baseline was less than 1%, and the factor 8 level came back at 150%. And so right then I knew that this was incorrect. However, outside hospitals may not know this. And so if it does come back, if that's the only factor 8 activity that they have at their hospital and they use that and they check it and and they don't know that there's the potential for this interaction, they may say, oh, well, this patient doesn't know what they're talking about. They don't really have inherited hemophilia because their factor VIII level is in the normal range. Again, also with the APTT, if you check the APTT, because the emicizumab will actually normalize it, this will also raise the potential suspicion that, oh, if the provider doesn't understand this drug, they may not know to interpret that correctly. And so I mentioned this again to help you advocate for yourself should you be in the situation of going to a hospital or an emergency room that does not have the testing capabilities if you're on emicizumab. So other adjunctive medications that can be used to help control bleeding, besides the drugs that I've already mentioned, can also be these drugs called antifibrinolytics. People here may know it as Amicar or Lyseta. This is really good at any type of mucosal bleeding. So think of bleeding in your nose, in your mouth, in the GI tract, or menstrual bleeding, because these are areas of high fibrinolytic activity, which is where these drugs specifically work. Now, there are several limitations to these drugs as well. And so the potential for clots, if you, again, it's a potential, a theoretical risk, but if you use it for prolonged periods of time, also it's contraindicated when patients have blood in their urine, because this can potentially cause obstruction with the clots if the medications are working well. And then it should also be limited with combinations of some of these bypassing agents as well. So you've now heard about how to treat bleeding. Now, again, the management of inherited hemophilia with inhibitor is twofold again. And so the next step is eradication, or getting rid of this inhibitor. So the standard of care is immune tolerance induction. It can be called sometimes ITI, sometimes it's called ITT, which is immune tolerance therapy. And what it is frequent and regular exposure to factor concentrates. And this can be factor VIII or it can be factor IX, but typically with factor IX products, that they would not be used in this situation because there is the high potential for allergic reactions to factor IX products if factor IX inhibitor patients do present. And so typically how this is administered is in much higher doses over several months to years to try to essentially overwhelm the immune system and just get the immune system to accept the factor replacement as normal things in the bloodstream. And the reported success rate ranges anywhere between 68 to 83%. The International Immune Tolerance Study is really the only prospective randomized study that has been done to look at the efficacy of ITI in patients with severe hemophilia A and good risk factors. And this study noted that the overall success rate was consistent with the previously reported rate of around 70%. And then this study also showed that there was really no difference between a low dose factor VIII regimen or a high dose factor VIII regimen. And so there is, from this study, we also saw how do we kind of break it up as far as good risk versus poor risk. And again, this is specifically for inherited hemophilia with inhibitor. And so good risk features include a younger age at which the ITI is started, and a lower lower historical peak titer, and then also a lower pre-ITI titer, as well as a quicker time to response with the titer decline. And so the poor risk features are listed here as well. Some of the predictors of how successful patients will be with ITI are listed here and do include the characteristics that kind of fall under the good features that were listed on the other slide. One additional characteristic is a low risk factor VIII genotype. So these could include small insertions, deletions, and also missense mutations. And this is where the genetic testing would come in handy for the inherited hemophilias with inhibitor. Now, with the advent of emicizumab and the approval of emicizumab, there are a couple of retrospective studies that were done, and one being the Atlanta protocol. And this protocol here looked at using concurrently emicizumab with ITI and looking at how well these patients did and their outcomes. And so this was very positive. And so because, again, this was a study just at one center at Emory here, that there is a larger clinical trial that's currently undergoing right now that are comparing those who are just on ITI with factor, those on just emicizumab, and also those using this Atlanta protocol as well. And so again, more prospective studies, meaning studies that kind of have already defined characteristics and then kind of watching patients move forward, are necessary to really compare the treatments and the outcomes adequately. So moving back to acquired hemophilia with inhibitor, this is also twofold as far as the treatment for acquired hemophilia with inhibitor as well. Now, again, it's still treatment of bleeding. The general categories are still treatment of bleeding and eradication of inhibitor. Now, with the treatment of bleeding, there is a big caveat. So if there is no bleeding, then about 30% of these patients actually don't require any of these medications that I have listed here for treatment of bleeding. And their main goal of therapy is eradication or getting rid of the inhibitor. And so with the treatment of bleeding, again, it is broken up into low titer and high titer. And the majority of patients who present, typically, if they're low titer, they generally don't have any bleeding. And so they would not need to use any factor VIII products. But if they did, then the human or recombinant factor VIII products could be useful. Now, with the higher titer inhibitor patients, as you can see, there are some medications that are similar to the inherited hemophilia with inhibitor treatments. But then there's also some that are unknown, such as the emicizumab. The emicizumab has not been well studied in the acquired hemophilia population. And so not much is known as far as the ideal dosing and whatnot. But then another medication that has been approved is something called porcine factor VIII, and that's known as pig factor VIII. And I'll go into that a little bit more in an upcoming slide. So this slide here, again, it compares the two, or two categories of bypassing agents, as mentioned before. So this is the exact same slide as before, but it can be used in the acquired hemophilia with inhibitor population. Now, one of the things is because of the potential thrombotic risk with the APCCs, you may want to be a little bit more careful with using this in patients with cardiovascular disease. Now, again, remember with acquired hemophilia with inhibitor, these patients are older. And so they do have pre-existing conditions that they're also living with. And some of them may be that they've previously had a heart attack. And so if the APCCs are considered, then a slightly lower dose may be warranted in order to still control their bleeding, but not increase their risk of thrombosis. And so that is a different consideration than, again, with that of inherited hemophilia with inhibitor. Again, with these patients, and that should actually say AH, so I apologize, but this is the same slide as before. And so antifibrinolytics such as Amicar and Lyseta can also be used in these patients with acquired hemophilia. And so the drug that I mentioned before, the recombinant porcine or pig factor VIII, this has actually been FDA approved specifically for patients with acquired hemophilia with inhibitor. Now, it has been shown to work effectively in patients with acquired hemophilia with inhibitor, but the pig porcine factor VIII inhibitor titer has to be less than 20. And so again, this is typically a send out test. And so it does take a little bit of time to come back. This is a drug that should be considered in patients with pretty severe cardiovascular disease or high risk factors for cardiovascular disease, as it has not been shown to be high thrombotic risk or high clotting risk, I should say. Now, one of the downsides with this is that it is only used to, or it can only be monitored with one-stage factor VIII activity. And so having real-time one-stage factor VIII activity results are really needed in order to dose this properly. Now, there has not been much published about what the results are if chromogenic is used. But again, with the package insert, it does say specifically to use the one-stage factor VIII activity. Now, just touching on emicizumab for the acquired hemophilia population, it is not FDA approved, but there is a clinical trial that is going to evaluate this. According to clinicaltrials.gov, which is the national trial site that has all the different, actually international trial site, that has all the different types of clinical trials going on. You can go there and you can type in the condition, the medical condition, and then you can search it by different states or different centers and whatnot. But understanding the optimal dose for emicizumab in this population is unclear. And then also the current practice, because there are some providers that are using this off-label, the current practice is to discontinue it after the factor VIII activity reaches greater than 30%. Because by then, again, these individuals, they have a history in the past of making their own factor VIII. So making the factor VIII is not an issue for acquired hemophilia with inhibitor. It's the inhibitor that is causing the factor VIII levels to be lower. Which brings me into what are different inhibitor eradication or elimination options. So through the multiple years of research, the three cornerstones of treatment include corticosteroids. Corticosteroids can include medications like prednisone or dexamethasone, and then cyclophosphamide and rituximab. So there's different changing guidelines as far as the best ideal immunosuppression. And so a couple of different categories exist. One is using steroids alone. One is using steroids with cyclophosphamide, and one is using steroids with rituximab. Now, if you look at the dosing of the rituximab dose can be one of two doses. So 375 milligrams per meter squared. So if you're an average weight person, you have about 2 meters squared, meaning that the average dose is somewhere between 600 to 800 milligrams of rituximab for that upper box. Whereas there are some low dose regimens that use the lower dose of 100 milligrams. Now, as far as remission with these treatment options, it ranges somewhere between 60 to 80% after a median of about 5 to 6 weeks. And so these recommendations are gathered from different surveillance studies and registries that have been conducted primarily over in Europe. And they've been listed, and they're listed here, but the best immunosuppressive regimen is unclear. So one of the studies here that does show kind of more of a progressive additional protocol is this here. And so what happens is within the first 3 weeks, if there's no remission, then cyclophosphamide gets added. And then after another 3 weeks, if that doesn't work, then rituximab is also added. And here with this protocol, you can see that the PR and CR, just so that you know, that stands for partial remission and complete remission, okay? And the term remission is really important to kind of understand because that will play a role in kind of what your condition is kind of in the future, okay? So kind of having a better understanding of that is important, especially to help you if you need to undergo future procedures or surgeries. But you can see here that about 61% did achieve complete remission, whereas 83% did achieve partial remission. And depending on the studies, partial remission versus complete remission is defined slightly differently. And so with this study in particular, partial remission was defined factor VIII activity of greater than 50, no active bleeding, and no need to be on drugs to control bleeding. But there was still a detectable inhibitor titer. And with complete remission in this study, it was defined as those characteristics plus a negative inhibitor, as well as other immunosuppressive medications had been stopped. And so looking at all these guidelines, in 2020, there was actually an international acquired hemophilia guideline that came out. And so these guidelines specifically use prognostic markers like factor VIII activity as well as inhibitor titer to try to individualize the immunosuppressive therapies. And as you can see on the left, if you had a factor VIII level of greater than or equal to 1% and inhibitor level of less than or equal to 20 Bethesda units, then that was the immunosuppressive protocol for you on the left. And then on the right was that of if your factor VIII level was less than 1% and greater than 20 Bethesda units. And so again, I think that kind of looking and understanding the complications of immunosuppression is also very important, because, you know, it's a balance between trying to get rid of the inhibitor, but then also just making sure that you understand what the risks are. So, you know, in these studies, it did show that infection was a big complication that did occur, as well as some people did develop infections that were bad enough that led, unfortunately, to their passing. Now, complications of daily prednisone can also be taxing on the body as well, because it can cause hyperglycemia, which is high blood sugar, hypertension, and then also ulcers in the stomach or the GI tract, as well as also muscle weakness, which is the myopathies, and also it can cause psychiatric disorders as well. And so kind of taking all of these potential complications, there is also a low dose combined immunosuppressive therapy agent or therapy regimen that can be used as well. And this was based on a retrospective study, meaning they looked kind of back on their institution back in 2013 that showed that even with this lower dose of both the steroid and the rituximab, patients actually had a good rate of complete remission, and they had improved side effect profile as well as mortality rate. Now, I will admit to you again that there is a lot that is still unclear, and it's not standardized in the US. It's definitely not standardized in the US. It's not standardized in the world either. But the complete remission rates are very are suboptimal. And so, you know, trying to work towards a better complete remission rate would definitely be ideal. Now, the time to remission really kind of depends on the patient and also depends on their pre-existing conditions. And so this can vary from weeks to months. And there's also a high relapse rate. So when your doctor tells you that you are in remission, that means that you know, you are essentially back to kind of where you were prior to this condition. However, with our patients, we follow them pretty closely because the relapse rate is pretty high within the first year. And so, you know, making sure that you get monitored regularly, especially in the first year after your treatment, is really important. So general recommendations for those with an inhibitor, and again, this is applicable to both inherited and acquired, would be to try to minimize procedures if possible, and then also delay procedures and surgeries that are optional until the inhibitor is under better control. Now, I recognize that sometimes procedures are not avoidable and necessary. And so this is where using bypassing agents or other approved hemostatic treatments can help you get through that treatment phase or that surgery. And so other kind of recommendations would be if you don't see a good clinical response within the first 20 or 12 to 24 hours, you may want to consider or advocate for yourself for changing to a different agent, and seeing how that works if it's available in your hospital or center. And then also just making sure that your hematologist is familiar with this condition. You can see, inherited hemophilia with inhibitor, that is more common than acquired hemophilia with inhibitor. However, even though it's a little bit more common, it doesn't mean that emergency room doctors are familiar with this diagnosis. It doesn't mean general practice doctors are familiar with this diagnosis. And so just making sure that you have a good team that's working with you to help you kind of guide you through this, okay? And so again, I think that through this talk, I hope that I've emphasized the difference between inherited hemophilia with inhibitor and acquired hemophilia with inhibitor are different entities, and kind of understanding the personal history as well as the family history are important and can help out with distinguishing between the two of this. And then also understanding that the laboratory testing for these conditions are very similar, but there are some different labs that can be run for depending on the condition. And then that treatment of inhibitors are twofold, and should definitely include bleed control as well as inhibitor eradication. And then continued research efforts is really needed to find kind of the optimal standardized treatments for anyone who develops an inhibitor. And so with that, I thank you for your attention. And I think we will move on to the question and answer session.
Thank you so much, Dr. Tran. This is just amazing. I'm going to ask Eric, can you bring myself, Janet, and Dr. Tran all up? And Dr. Tran, can you stop sharing your screens so they can see faces for the Q&A? And I just wanted to let everyone know, if you didn't get my message in the chat, we'll go for about another 10 minutes or so with the Q&A, which is amazing. And I'm going to give a very quick plug. I'm going to put a link in the chat. This is for next month's webinar. It is on September 6th at 4 p.m. Pacific time, 7 p.m. Eastern, and it's on joint inflammation and pain, finding the cause. We've got a dynamic duo from OHSU, Oregon Health and Science University. That's Becca Heckathorn, registered nurse there, and Nancy Durbin, a physical therapist. And a lot of times people in our community struggle with joint pain. Sometimes it's connected to bleeds, but there can be lots of other reasons as well. So we want to make sure that you have that information. So again, you can go to the link in the chat if that is something that interests you. With that, we have tons of Q&A. So we're going to just answer as many as we can in the time we have left. Dr. Tran, the first one, we had a couple of people asking about the difference between acquired hemophilia and spontaneous mutations. People asking, could it actually be a person with acquired hemophilia? Could it be that they had inherited hemophilia their whole life and now they think they have acquired hemophilia? Someone else is just asking the differences between acquired hemophilia and spontaneous mutations.
Sure, so that's a great question. And I think the easiest way to think about it is that those with acquired hemophilia would not have a factor VIII mutation. Okay, so you will be making, so with a normal factor VIII gene, you should be able to make regular amounts of factor VIII. And so with spontaneous mutations, if you were to check your levels, then they would be low. And so then you would check an inhibitor, or then your provider should check an inhibitor titer, okay? So with a spontaneous mutation, you will have low factor VIII levels, but you will not have a detectable inhibitor because, again, as I mentioned in my talk, with inherited hemophilia, if you've never been exposed to factor products before, if you've never been infused with factor products, okay, then you should have a 0 inhibitor, meaning it should not be detectable, okay, because you've never been exposed to that. And so your body would not respond to something it was never exposed to.
Thank you, Dr. Tran. Another question had to do with just the fear and realities with acquired hemophilia. So a person asked, I had a bleed and I ended up being diagnosed with acquired hemophilia, which was very scary. What do I do to prevent another bleed? Can I eat different foods? Can I change any of my behaviors? And can I trust when I'm told I'm in remission that I'm actually going to stay in remission? So I guess it's a scary thought that you might have another spontaneous bleed and end up back where you were.
Yeah, so definitely there's a lot that is not known about acquired hemophilia. And one of the reasons why it's not known is that it is such a rare entity, okay? And so one thing to think about is that, again, this is where being an advocate for yourself is really important. So when your doctor says that you're in remission, things to ask is, what was my last factor level? What was my last inhibitor titer? The factor 8 level should be greater than 50%, and the inhibitor titer should be less or not detectable, okay? And so kind of confirming it yourself and hearing it from them that, you are indeed in remission. And I think that the having regular follow-up with your doctor. So again, the first year after treatment is the highest rate of relapse. And so I had one patient, for example, who did really well on the immunosuppressive therapies, and his levels went back up to, I think, 150%, and his inhibitor titer was negative. And I told him, okay, you have to keep following up with me regularly. And when I say regularly, I mean at least every 1 to 3 months, okay, depending on kind of the practice. And he did that well for the first 6 months, and then afterwards he just dropped off the face of the earth. Like, we tried to call him, we tried to get him in. He said he had busy schedules, he couldn't make it to the lab. Well, unfortunately for him, 4 months later, I get a message, I need to be seen by Dr. Tran immediately. I'm starting to have bruising all over the place again. I don't know what's going on. So, obviously we got him in and we tried to check his levels, and his factor 8 level was down to, I think, 5%, and his inhibitor titer was back up again. And so, the rate of relapse is really high. And so just because you're told that you're in remission, I think getting regular monitoring is really important. And also, oh, go ahead, sorry.
I was just going to ask, and what do you recommend if if someone suspects a bleed with acquired hemophilia?
Yeah, so if are we talking about patients who are already in remission?
Yeah.
Okay, if they're already in remission, then theoretically, you should have normal factor 8 levels, right? So the first and most important thing is to go to either a lab or an emergency department and get your factor levels checked. I would not recommend using bypassing agents or Emicizumab or PIG factor 8 or any of those products, because theoretically, if you're in remission, okay, you should be able to clot like you did 10 years before you were diagnosed with acquired hemophilia. And that is really, that brings me to an important case that I actually had recently happen. So this lady, she was treated for acquired hemophilia, and she again did really well, and her levels were in the 100%. She wanted to get hip replacement, okay? And we checked the levels the day of surgery, and it was 110%. Anesthesia looked at that and said, oh, you have a history of acquired hemophilia. I don't feel comfortable with allowing this procedure to proceed, even with a normal factor VIII level. And despite talking to me and letting them know that she's in remission still because the factor VIII level occurred that day, they said, no, we have to move her to a different hospital in order to have that procedure, which again, this is where making sure that the community of medical providers is knowledgeable about this diagnosis is really important because it is such a rare condition. And so because they weren't familiar with it, they were uncomfortable with proceeding.
So Dr. Chan, this is a really interesting question, and certainly one that comes up in light of where we're at right now with COVID and other realities. But they're asking, do you think that there's a connection between COVID and acquired hemophilia? And they say that they've gotten 5 new patients with acquired hemophilia in the last 6 to 9 months at their HTC. So they're wondering if there may be a connection.
Yeah, so we do know that infections are a potential association with acquired hemophilia. I don't think that we necessarily know what the triggering factors are, but infections are one of the things that can essentially put your body into kind of a high defense mechanism. Okay, and so so with your body kind of responding to infections in general, that can be a trigger to, okay, well, I'm going to, put up all these defense systems, but maybe one accidental defense system gets through and says, oh, well, I'm recognizing your own factor VIII as a potential foreign substance, and it could potentially cause that. But, to the person who asked that question, we don't have any great, reports for that. And I think that, if the association is occurring that commonly, I think that would make for an interesting case report or case series, I should say. And so definitely, that is something to consider, kind of, being, or I should say, that is something that is worth asking at some of these national meetings that are coming up as well, to different providers.
We still have lots of questions and more keep coming in as you're answering them. I'll go ahead and send a few more your way if you all still have time to answer them. And for those who can stay on. The next one is saying, as a patient with factor VII deficiency, I've heard that there are some in our community who have developed inhibitors to their clotting factor Novo 7. Can you speak to this?
So I am not familiar. I mean, so factor VII, so again, with factor VII deficiency, you're introducing outside products, right? So that, I think the potential for inhibitor is always there. Now, I cannot say I'm all that familiar with how frequently that happens. I'm assuming that must be even more rare than the conditions that we're talking about today. But I'm not familiar with how commonly that does occur.
Can you answer the question, can inhibitor level decrease without the tolerance procedure?
So yes, it can decrease without the tolerance procedure. But again, it is dependent on what you are exposed to. I mean, it depends on which condition you're talking about. So with inherited, if you don't expose yourself to factor outside factor products, then the inhibitor titer will go down over time, okay? But as shown with, and this is before the arrival of emicizumab, but with the bypassing agents, the efficacy rate was only really about 80% at controlling bleeds. And so not ideal for patients if they're having multiple bleeds, because that's only, 4 out of 5 bleeds really get under really good control. Whereas with, if you get tolerized and you can use factor products, again, this is for inherited, then you would essentially be able to infuse up to 100%, and that treats your bleed. That has been shown to treat bleeds much more effectively. Now with acquired, again, so 30% don't have bleeding issues, okay? So if you get diagnosed with acquired hemophilia and you want to wait for your inhibitor titer to go down, I'm not sure how quickly it'll go down. And so, the patient that I mentioned to you about, the woman who wants the hip replacement, her hematologist in her city actually, when she was initially diagnosed, he said, you just can't have any more procedures for the rest of your life, period. Like, because she wasn't bleeding, and so she didn't need to be on any products, but he didn't even offer immunosuppression therapy. And so if you, again, anticipate that you're not going to need any procedures, but it's kind of, you kind of are rolling the dice, because if you do need a procedure, it's a little bit too late to start immunosuppression. And so the answer is yes. I think over time it can potentially go down for inherited. With acquired, that information is less known, just because there can be other comorbidities or coexisting conditions that can cause you more harm as well.
Thank you, Dr. Tran. There's no way we're going to get to all the questions, which is amazing, because that means that we're just going to have a part 2 at some point, which will be wonderful to continue the conversation. I am going to give our final question this evening to Janet. Janet, we know that individuals are impacted, their mental health is impacted when they end up having an inhibitor diagnosis within their family. And they're asking, what do you say to someone with a new diagnosis who suddenly finds out that all the tools they thought they had in their toolkit to treat hemophilia aren't necessarily available, and it becomes quite scary for them, as a parent? So what do you do or say to support a parent or a person who's suddenly been diagnosed? And I think this is applicable to acquired hemophilia as well, that fear.
Absolutely. It's a great question, and thank you for passing that off, Shelley, because actually that did happen in our family. I knew I was a carrier. I had 2 boys with hemophilia, and my youngest son developed his inhibitor at the age of 10. And it was like a lightning bolt out of the sky, because we truly never expected that to happen to us, but it did. And there's all kinds of it doesn't really matter what the reason is anymore. I used to kind of try to figure out what that was and what I could do to fix that. But I think the very first thing that I think you should do is just take a deep breath. Know that it's going to be okay. Learn as much as you possibly can. Talk to every person that you can think of, whether it be your healthcare professional, whether it be your clergy, whether it be a trusted friend, a family member, the hemophilia community as a whole. Talk to manufacturers. Try to gather as much information as you possibly can. If you're going to go on Google, look for scholarly articles, please, that have come from trusted resources and physician researchers who actually have studied this. a shameless plug, feel free to reach out to me. I'm always happy to, I spend a lot of time counseling parents and families on what it's like to deal with that diagnosis. Like I said at the top of this call, first and foremost, I'm an inhibitor mom. But again, keep going back to, the national organizations that specialize in this. And your healthcare provider really is your first line of information. But I also know that there are families who have had problems with, getting information from their healthcare provider. So don't be afraid to ask questions, be thoughtful, be respectful. I've often said to families, you get way more with honey than you do with vinegar. We're all on the same team. And it's real hard not to go mama bear on everybody. I so get that as a mama bear. But we're all here together to support each other. And, it's a great team of people. It's a great community. Talk to each other people with an inhibitor. It's really important. The more we can get together, the more we can talk to each other, the more we can learn.
Thank you so much, Janet. And I want to thank all of you. So many of you stayed on because this is such a critical topic. The fact that we have so many people, a majority of the people still on after we have run significantly over, really demonstrates how critical this information is. So I want you to know that this will not be the last time that we present on inhibitors and acquired hemophilia, and not the last time that we invite this incredible duo to come present and share information. I want to take a moment and thank Janet and Dr. Tran for sharing with us. It's been a fabulous time, and I really appreciate all the critical information that both of you have shared with our community. A survey will pop up at the end. Please share any questions or other thoughts you have so that it will inform the future webinars, and it will help us with when we're looking at a possible encore presentation about inhibitors and acquired hemophilia. Thank you all, and I hope you all have a good evening. Take care, everyone. Good night.
Good night.